Well, hello, buenos dias, good morning, good afternoon, or good evening, depending on where you're joining us from. And welcome to Engineering for Change, or E4C for short. Today we're very pleased to bring you the latest in E4C's 2013 webinar series. Our webinar today was developed in collaboration with Villanova University, and our guest presenter is Pritpal Singh. My name is Yana Aranda, and I'll be moderating today's webinar. When I'm not moderating webinars, I am working with the American Society of Mechanical Engineers, or ASME, where I am a senior program manager. I'd like to take a moment now to tell you a bit about today's webinar on the subject of using low-cost communications and computer technology to improve the quality of healthcare in rural Nicaragua. At E4C, we're constantly on the lookout for novel solutions in the field of information and communication technologies for development, otherwise known as ICT4D. So we're especially excited to have Professor Singh, the chairman of the Department of the Electrical and Computer Engineering at Villanova University, joining us today to share some of his insights. Thank you for being with us today, Professor Singh. Before we get rolling, I'd also take a moment to recognize the coordinators of the E4C Webinar Series in general. Along with myself, we have Polly Schneider-Brown and Victoria Chung and Alex Torres of IEEE, who work on developing and delivering the webinar series. Thank you, team, as always. If anybody out there has questions about the series, please feel free to contact us via the email address visible on the slide, webinars@engineeringforchange.org. Before we hand things over to our presenter for today, we thought it would be a good idea to remind you about the Engineering for Change organization and who we are. E4C is a global community of now over 13,500 technically minded individuals, such as engineers, technologists, representatives from NGOs, and social scientists who work together to solve critical humanitarian challenges, whether in water, energy, health, agriculture, sanitation, or other areas faced around the world today. We invite you to join E4C by becoming a member. E4C membership provides cost-free access to a growing inventory of field-tested solutions and related information from all the members of our coalition, including professional societies like Engineers Without Borders USA, IEEE, ASCE, SWE, and ASHRAE, as well as academic supporters like ASU's Global Resolve Program, Santa Clara Center for Science, Technology, and Society, and international development agencies such as USAID and Practical Action, as well as a passionate, engaged community working to make people's lives better all over the world. Registration is easy and it's free. Check out our website, engineeringforchange.org, to learn more and sign up. The webinar you are participating in today is one installment of the Engineering for Change webinar series. This free, publicly available series of online seminars showcases the best practices and thinking of leaders in the field who bring innovative technology and solutions to bear on global humanitarian and development challenges. Information on upcoming installments in the series, as well as archive videos of past presentations, can be found on the E4C Webinars page, listed here. If you're on Twitter, we'd also like you to invite you to join us in a conversation using the hashtag E4C Webinars, also listed here. For those of you who are curious about how to access the presentation following today's webinar, you can also find us on the YouTube channel for Engineering for Change. It's listed here, and this is where we'll post the presentation afterwards. E4C's next webinar will be on June 5th at 11 a.m. Eastern Daylight Time with Radha Basu, who is the director of the Frugal Innovation Lab at Santa Clara University School of Engineering. The subject of the webinar will be Sustainable Solutions for Emerging Markets, Technology, Innovation, and Livelihoods. To register, please visit the E4C Webinars page listed here. A few housekeeping items before we get started. I'd like to see where everyone is from today who is joining us. So we'll do that by asking you to type your location in the chat window that's located on the right of the screen. I'll go ahead and get started just to show everybody what I mean. Any technical questions or administrative problems should also go into the chat window on your right. Please feel free to send a private chat to myself or Holly during the webinar. I see we have a lot of folks from all over the world today. Very exciting. Singapore, Canada. I saw some folks from India. Welcome. Welcome all. During the webinar, if you have a question, please use the Q&A window located below the chat window to type in your questions for the presenter. That way we can keep them all in order and make sure we tackle them all at the end. If you are listening to the audio broadcast and you encounter any trouble, try hitting stop and then start. If that does not work, you can use the call-in number for the teleconference. You may also want to try opening WebEx up in a different browser. Following the webinar, to request a certificate of completion showing 1 professional development hour, or PDH for those of you who need this for your engineering certifications, please provide your full name and date you completed this webinar, as well as the code that we will give you at the end of the session. Compile all of that and send it to eab-ceuadmin@ieee.org, and you'll receive your PDH hours. Fantastic. Thank you so much for sharing where you guys are from. So I would like to introduce to you today's presenter, Professor Pritpal Singh. So we're very excited to have Polly. He is the professor and chairman of the Electrical and Computer Engineering Department at Villanova. He received his Bachelor of Science in Physics from the University of Birmingham in England in 1978, and his PhD in Applied Science Electrical Engineering from the University of Delaware in 1984. Dr. Singh teaches courses at the undergraduate and graduate levels in the areas of semiconductor microelectronics, analog and digital electronics, optoelectronics, power electronics, and renewable energy systems. His research areas include solar cell development, battery and fuel cell modeling, and environmental energy harvesting systems. Polly has published over 100 conference and journal articles and holds 6 U.S. patents for estimation of state of charge and state of health of energy storage systems, and for novel energy harvesting technologies. His recent work has focused on the development of low-cost tech to improve the lives of people earning less than $2 per day. And that is what brings him to us today, and we're very pleased to turn the presentation over to him.
Thank you, Ayana, for that very kind introduction, and good day to everyone who's tuned in for this webinar. It's my pleasure to present this work that we've been doing down in Nicaragua using low-cost communication and computer technology to improve the access to rural Nicaraguans of quality health care. So the outline of my presentation today is I'll start off by giving some context to the project, and it's really a multidimensional program involving healthcare, social and technical aspects, and then economic parameters. We'll look at the dimensions of the challenge, as I said, the human medical side, the nursing and medical professions. I'll then get into the technical side that we've been working on, and then look at the economic factors that play into this project. I'll talk about the progress to date, followed by partners that we've been working with, and these have been very important in terms of moving this program forward. And then I'll be pleased to introduce my colleagues who are working down in Nicaragua, Claudia Castro and Maria Virginia Moncada, who are going to give some testimonials in terms of the impact of the project, and then we'll get back to my describing where we're moving forward with this program. So just to give you a little bit of background, there are a number of general challenges working in this part of Nicaragua. It's a beautiful country, mountainous part of the country, but there are a number of issues such as poor infrastructure, generally low level of education. The civil war that took place in Nicaragua back in the 80s between the Sandinistas and the Contras has resulted some residue of the civil war. Still, you have factions of Sandinistas and Contras in this region, people who are armed and so on. So there's still some residue from the civil war. Generally, this communities here are low-income communities, and the language and cultural barriers as we try to work down there. So those are general challenges, and I'll address these in more detail later on as we go through the presentation. So the area that we're working in is North Central Nicaragua, in the town of Waslala and the surrounding communities around Waslala. So the communities, there are about 92 rural communities surrounding a central town, and the regional population of this area is about 50,000 people. It's very rugged terrain, as you can see from the photograph on the right-hand side here, and many cases you don't have paved roads, so you know, in some cases the only way to access the communities is either on foot or on horseback. And because of the remoteness of this area and the ruggedness of the terrain and inaccessibility, the access of these community members to quality healthcare is very limited. So the goal and motivation for our project is really to improve the quality of healthcare that is available and is accessible by mostly these farming rural community members in the region surrounding the town of Waslala. So if you look at the town of Waslala, there is a hospital here that's run by the Ministry of Health. Healthcare in Nicaragua is free. It's run by the Central Ministry of Health. And this one hospital here in Waslala, which is in the town center, has very limited resources. So for example, there isn't a working x-ray machine there. If a patient needs to have a cesarean section done, they don't have surgeons to be able to do that, and they have to go to Matagalpa to be able to get that type of surgery done. So very limited resources in terms of the hospital. And if you look at the number of trained doctors that serve the Waslala and that whole rural communities around Waslala, there are only 6 trained doctors that serve those communities. So most of the communities are served by, sometimes you'll see the term community health worker used. We're using the term community health leader because these really are leaders who are trying their best to serve their community members in terms of supporting their health needs. So the community health leaders are volunteers who serve their own communities. They're a member of the community who has volunteered to provide health services to their community members. Typically they have limited education, could be as low as second grade education as the extent of their education. And but at the same time they're trained by various agencies, including the non-governmental organization that we're working with, ADES, which stands for Asociación Desarrollo Integral y Sostenible, which basically is the Association for Development and Integral Development and Sustainability, to extend the reach of medical services and health information out to these health leaders. So this project, this is a picture of the community health leaders that we're engaged with, and you can see it's a variety of people of different ages, both men and women serve as volunteers in their communities, and these people are really very dedicated to trying to do the best for their communities that they can. So, as I mentioned earlier, this is really a multidisciplinary project. We've had collaboration between our nursing school here at Villanova University, the engineering college, and then also the business school. And we've also had participation from our College of Liberal Arts and Sciences. So it's really a multidisciplinary program. So there are 3 dimensions to this challenge. The first is the human factors and training the health leaders to be able to deliver both measure vital signs competently, as well as be able to determine the health assessments of their individuals in their communities. Then the technical factors are setting up this communications and computer infrastructure, the ICT infrastructure to be able to support this program. And then economic factors in terms of what are the costs of running such a system and how could we potentially make this sustainable. So let's focus initially on the first dimension, the human factors, the nursing challenge. So as I mentioned, there's 92 rural communities, and the accessibility is limited. You may need to travel only an hour to get to some communities close to town, but it could be up to 14 hours when it's possible. Sometimes during the rainy season, the unpaved roads are washed out and they're not accessible, other than by foot or by horseback. The community health leaders are the primary healthcare contact in these communities, but they lack basic medical equipment such as thermometers, blood pressure cuffs, stethoscopes, and so on. And they need training in basic physiology, measuring vital signs, preventive care, basic health assessments, and not listed on this list, but very importantly, is documentation related to individuals that they're measuring vital signs on. So the immediate healthcare goals is to really provide rapid, real-time, computer-assisted assessment help to the health leaders from a healthcare professional who's affiliated with the Ministry of Health. We want to develop an infrastructure to create, store, and retrieve patient records. And then we talked about equipping and educating and training the community health leaders. So in terms of equipping them, providing them with the blood pressure cuffs, the stethoscopes, the thermometers, and so on that they're lacking, and then training them in terms of being able to adequately and competently measure vital signs, as well as looking for symptoms of potentially fatal diseases or complications from pregnancy and so on. We want to obtain an accurate baseline data because that's very much lacking in this particular region. And once we have that data, then we can see the impact of the interventions that we're doing in terms of improving the quality of healthcare that the community members in these communities are receiving. And we're also aligning the outcomes that we're trying to measure to match national goals. So for example, our focus has really been on pregnant women and infant development. So one of the things that the National Program Ministry of Health wants to achieve is prenatal visits with skilled professionals 2 or 3 times before a woman delivers a baby. And then if possible, have the woman come to a hospital to deliver with a skilled attendant. So these are national goals that we're trying to align with in terms of our program. So the second dimension is the technical side. And as I said, trying to reach out to these rural communities, many times these communities are a long distance from the town or can be quite inaccessible. You can see on this picture here, we're fording through a stream to get to one of the communities. And this is at a point in time that you can actually drive through. Oftentimes during the rainy season, one wouldn't be able to pass this type of stream. So, it is something that is not easy to, the terrain is not easy to access. And so using some other technology that can access these rural communities was something that we wanted to consider. In these rural communities, few have access to electricity and there's almost no access to the internet. However, there is cell phone service widely available, although not everywhere. And there is one single tower in Waslala, And so oftentimes in some of these more remote communities, in order to get a cell signal, the community health leader has to actually go to the top of a hill or at some higher level to be able to just get a signal. So the solution that we came up with was to equip the community health leaders with inexpensive cell phones, very basic phones that are low cost, and we're simply relying on their capability to be able to text messages. So we're not looking at internet access being necessary, really very basic cell phones. Because again, coverage in these areas is very spotty, and we didn't want to be restricted by the capabilities of the phone and the requirements for the phone. And then set up an information and communications technology system, an ICT system, for collecting and transmitting patient information, storing and organizing that data in electronic health records, and then providing health assessments and remote medical advice from a healthcare professional back to the health leader that they can use then for following some intervention that might be required for a particular individual. So this is a system-level block diagram of the system that we established. So if you look to the left, you see the cell phones that we provide to our community health leaders. And we also have to provide them with some charging capability, solar chargers, for them to be able to text in the information to the computer from the vital signs that they're measuring. And then that's texted into a modem that is linked to a medical computer server that has software built into it to acquire the data and store it in an electronic medical record. We have a router to be able to send that, to be able to access the medical server remotely, either from the Ministry of Health nurse or doctor's computer, or for us to be able to remotely access it from Villanova to be able to make updates to the software on the computer, as well as to be able to look at what data is being acquired by the computer. So in terms of hardware system components, as I said, we're using some basic mobile phones that are not Java enabled, typically from Samsung and Nokia. A good example is the Nokia 1660 model. And then we've tried a couple of different solar chargers. One that we originally started with was the Solia Rockstar H1000, which has a 0.6 watt solar panel and 3.7 volt, 1000 milliamp hour lithium ion battery. More recently, we've found that another model that has a little bit higher capability in terms of provides 4 watts of solar electric power and has a larger battery of 4,000 milliamp hours, so that you can charge the cell phone battery multiple times from a single charging from the solar panel. So the design philosophy falls into two categories. We want to have reliable, low-cost hardware. So low power consumption is important, and we initially settled on this Dell PC, an ultra-small form factor computer with the 10 gig hard drive and a very high efficiency power supply. We are looking at some other platforms to transition over to, but this was the best that we could find when we started the project 3 years ago. And then the other part of the design philosophy is to use open source software. So for example, we're basing everything on Linux operating system. We're using MySQL database, and we're building it on a rapid SMS platform, which I'll describe in a little more detail next. So rapid SMS platform is based on Django, a popular web framework Python interface, and it's an open source software which can be programmed to send out and receive SMS messages via a cellular modem. It can store data in a relational database, And then it also provides the GUI interface for displaying fields in the database. So this is really a very well-developed, useful platform that we adapted for our particular project. If we look at the server software, the capabilities of the software on the computer server that we're using, we have a web interface to build and modify submission forms. And we can create these forms and update patient records. We have multiple views, so a doctor view that can be restricted to look at patient histories and reports. And then an administrative interface to manage patient records, the community health leaders for registering them and so on, as well as forms for administration. So if you look at the format of the data, we have, for example, the date of birth of the individual, so the name and the date of birth, and whether, and then fields for different vital signs and so on. And so this data would be texted in a particular format that we've decided, and also aligns with the Ministry of Health format for data storage. And then we worked with the community health leaders to teach them how to correctly text this information into the computer server. So here's a screenshot of what would be a page with the different patient names and the health leader who put the information in, the date that it was sent in, and so you can see a record of all the texted data that from when it was texted in. And this is a screenshot of patient data, so you can see the ID number, that's the national ID number at the top there, the name of the patient, and the date of birth of the patient, which of course I've covered up to maintain confidentiality of the patient. And then what's the name of the health promoter who submitted the information, the date it was submitted, the telephone number, and then some vital sign information. So you can see the blood pressure here, the pulse rate isn't indicated, and then breathing rate and so on. So this is the data then that can be viewed by the healthcare professional, and if any intervention needs to be done, then this can be fed back to the health leader. One of the issues that we run into in this area is the power supply is not very reliable, and so we installed a backup power supply based on a solar electric system in the health office there in Waslala to be able to support making sure that the computer server was up during all times. The third dimension is economics, and so here are some of the costs that are involved in running this program, broken down between annual fixed costs as well as one-time costs. So for example, the cost of the phone, the solar charger, and so on, those are things that are one-time costs. Although we may need to replace medical equipment periodically. Sometimes we have to replace phones and solar chargers if they break. And then there are yearly fixed costs for supporting doctors and technicians. So we've been working on trying to come up with a sustainable business model to support this program, and we have some ideas that we're starting to explore, but this is still an avenue that needs development. So to give you an update on where we are in the project to date, we've made several trips down to the site. The first trip we made in May of 2010 to do an initial site assessment, and we had a team of about 25 electrical computer engineering students and faculty, nursing students and faculty, and business students and faculty, and we were assessing things like the capabilities of the health leaders, what are the backgrounds, what are the particular issues that they're dealing with, We looked at the availability of cell phone signals in some of the communities, and then the business students were looking at how business is conducted in this particular region. We've established an in-country office staff, including a project manager, an office manager, and 2 nurses. We've equipped the MINSA nurse, the Ministry of Health nurse, with a computer and modem to access the health records from her office. We've equipped 50 community health leaders with diagnostic equipment, cell phones, solar chargers, and trained them in taking basic vital signs. We've installed the server and the backup power system. We initially installed this in the health office in Waslala, but we subsequently moved it to the engineering school in Managua because we were running into problems with access to internet and reliable power, and it was just making it very difficult to really be able to keep the system operating and be able to update software and so on. We've created simplified manuals and text training video in Spanish, and we've developed, most importantly, several key partnerships to be able to run this program. So let me quickly describe what some of the partnerships that we've established. NCIA, which is the National Collegiate Inventors and Innovators Alliance, provided the initial seed funding for us to start this program back in 2010, and that's how the program got started through the Sustainable Vision Grant. We've subsequently gotten funding from Halloween Philanthropies to continue the program for another couple of years. Conley Foundation has supported travel for nursing students and faculty to work down in Nicaragua. ADIS has been our NGO partner in country. Claro is the local cell phone company, and they've been very generous in donating cell phones to the program as well as texting airtime. The nursing school in Matagalpa has been very important in terms of supporting our workshops, the health workshops for the health leaders, both during times that we've been down there. We've given workshops together, but also during times that we haven't been down there. And then we've also had a strong partnership with the National Engineering University in Managua in terms of some of the software development on the computer. And SUNY Solar was contracted with installing the solar electric backup system. We are developing a partnership with the Ministry of Health, and that's almost in place. And then we're also developing some new partnerships with a couple of other organizations. The organization Pro Mujer that has offices throughout Central America focused on microfinance, and the UN Population Fund. So we faced a number of challenges in trying to run this program. I talked about the lack of reliable electricity and internet connections in Waslala. The limited education of health leaders. We went in assuming a number of assumptions about the health leaders, and as motivated and as enthusiastic as they are, they lacked some basic education that we didn't realize. So, for example, for measuring pulse rate, you need to be able to tell time, and many of the health leaders couldn't tell time. So that was something that we had to overcome. But they're wonderful people, very motivated, and they've really risen to absorbing a lot of the information that we're working with them on and developing their competency. We've had a number of personnel changes that we've had to deal with, working in this area in terms of things that we think normally, you can just go down to a hardware store and buy things. Well, in Waslala, it turns out even to get wire nuts, we were not able to find those. A number of cultural issues are there. People are used to using natural medicines, so that's a cultural barrier that we've had to address as well. And then in some communities, they're not viable health leaders, so that's something that we're still trying to work around. So in terms of project impact, the health leaders are really proud and excited to be involved in this project. They're improving their education. Many of them have never owned or used a cell phone before, so they're just excited to own and use a cell phone. they're more respected in their communities, and the most important thing is that they're more confident in dealing with health problems. So we really feel that the health leaders are really benefiting a lot from this program, as well as helping to improve the quality of healthcare in their communities. Now what I'd like to do is to turn it over to Claudia Castro, who's the nurse who's been working with us in the Ministry of Health there in Waslala, and she only speaks Spanish. So Maria Virginia Moncada, who is the head of the Electronic Engineering Department at UNI, she has also been working very closely with us, and she's going to translate. And Claudia is going to give us two cases describing the health outcome impact of this project. So Claudia and Maria Virginia, I'll hand it over to you.
Good morning, everyone. My name is Maria Virginia Moncada, and I thank you for interest in this project. I'm going to introduce myself, and also I'm going to introduce Claudia Castro. She is the nurse working with us in the telehealth project down in the communities. Buenos días. Estoy presentándome. Mi nombre es Virginia Moncada y trabajo en la UNI, en el proyecto de medicina también, y también estoy presentando a Claudia Castro, que es la enfermera que trabaja con nosotros en el proyecto de Waslala. Voy a dejarle a Claudia la oportunidad de comentarnos algunos casos sobre experiencias en la comunidad.
Hola, soy Claudia Castro, la responsable de enfermería en el municipio de Waslala y también representante de AIS de la Asociación del Desarrollo Integral y Sostenible en Waslala. Voy a presentarles un primer caso de una niña de 12 años de edad en la comunidad de San Juan Yará, quien fue referida por el líder de salud, Clotilde López. Este líder atendió en su casa a la niña. Ella presentaba fiebre, le tomó los signos vitales y se pudo dar cuenta que esta niña tenía temperatura alta, la refleja como 40 grados. También otros signos que encontraron fue la respiración rápida y palidez generalizada. El líder me envió un mensaje para consultar cómo tratar a la niña en la comunidad. Luego yo le envío la respuesta y el líder me dice si puede dejar la niña en la comunidad o tiene que trasladarla. Inicialmente decidimos que la niña iba a comenzar un tratamiento en la comunidad y se le explicó al líder cómo hacerlo y cómo indicarlo. Luego el líder me llama a los 5 días diciendo que la niña sigue igual y que más bien está empeorando y que esta vez ha notado un nuevo síntoma en signo que es rigidez en la nuca. Inmediatamente le digo al líder de salud que esta niña debe ser trasladada al Hospital Fidel Ventura para ser mejor valorada aquí por los médicos y el especialista.
Well, these are part of the testimony that Claudia Castro is sharing with us. She's talking about different cases. First, she's going to talk about a 12-year-old girl. She is from the community of San Juan Llaro, down to Waslala. And Claudia knew about this girl through the health leader, Clotilde Lopez. They were using the SMS system we are already set up in Waslala. And the leader attended the girl, and she was presenting fever, and she also was presenting high temperature and rapid breathing and illness. Then Claudia asked the leader to take care of the girl, and she asked for the symptoms. The symptoms were giving out first diagnosis, and Claudia diagnosed it as a urinary tract infection. So Claudia, you can continue. Claudia, vos puedes continuar.
Luego entonces que la niña viene al hospital, y en el hospital el pediatra la trata como una neuroinfección y es trasladada al hospital César Amado Molina de la ciudad de Matagalpa. donde estuvo hospitalizada. Ahí le realizaron una punción lumbar. Luego los resultados indicaron que es una meningitis bacteriana. La trasladan al Hospital La Mascota en Managua, donde permanece ahí por un mes. Luego, posteriormente, la niña fue dada de alta con un diagnóstico de meningitis resuelta. La niña perdió sus funciones motoras y la coordinación para la marcha a causa de la enfermedad que ella tenía. Pero la meningitis pues no provocó muchas secuelas de mayor gravedad gracias a la oportuna referencia del líder de salud hacia nuestro hospital, porque si la niña hubiese seguido en la comunidad, pues lamentablemente hubiese muerto y hoy en día está viva.
After the girl was diagnosed with urinary tract infection, the leader was giving to her the antibiotic, but the girl continued with fever and she was taking the same symptoms. Then Claudia was informed again by using the MS system, and they decided to take the girl to the hospital of Waslala. So Claudia did coordinate the transportation to the hospital and with the ambulance. Then they transferred the girl to the community, from the community to the hospital, and in the hospital of Waslala, the doctor suspected for a neuroinfection. So they take the girl to the hospital of Matagalpa, and they did some examination to her. They did a lumbar puncture, and as a result, they indicated that the girl was suffering from bacterial meningitis. During the time she stayed at the hospital, the girl falls into a coma, and she was taken then to Managua, to the hospital La Mascota. She was there for 1 month. After she was okay and the meningitis case was resolved. The girl lost her motion function and coordination marks because of the disease, but she still have better conditions and she is okay now. Okay, Claudia.
Virginia, I think given the time, we should probably just keep it to the one case, but I think that really describes the impact of the project in terms of this girl with bacterial meningitis. So if we have time, if we don't have enough questions, we can go to the second case, but I think we need to wrap up given the time now.
Okay, so I should say goodbye?
Well, no, you should stay on the line if people have questions. Okay. So if you and Claudia could stay online.
Okay, okay.
Okay, could you let Claudia know as well?
I will let her know.
Okay, thank you. All right, so let me move on to talk about our future plans. So we're in the process of adding flagging the software so that as the health records come in, if any of the vital signs are out of norm, then that particular health record gets flagged so that we don't have to have the health professional look at every record. And then we're also looking to build in some diagnostics and decision features to the software. We're in the process of building a project website, or actually websites, one in English, one in Spanish, with different levels of access depending on stakeholders. So a doctor would have a different level of access compared to a sponsor who's just looking at general information, whereas the doctor might need to look at particular patient data. We want to release the software that we've developed under an open source license, and we'll be exploring that. And of course, the key that we want to do is to measure and report outcomes and impacts of the project. Our goal is to try to cover all of the communities in Waslala. So right now we're covering 50 of the 92 communities, and we would like to cover all 92 by March of 2014. And then we're starting to explore other rural communities in Nicaragua. So our focus has been around Waslala and the communities there. We're exploring 3 other sites that we want to expand into, and looking to expand into at least 1 or 2 additional communities by October of this year. And then we'd also start plan to look at other Central American countries in late 2014, late next year. So, of course, many people have been involved with this project, students, faculty from our different colleges of engineering, nursing, and business school here, and arts and sciences here at Villanova. But we've also had a lot of collaboration with the engineering school in Managua, the nursing school in Matagalpa, as well as a number of supporters of the program. So we're very grateful for all of the people who've supported the project. And if you're interested in getting more information, since we don't have a good website up yet, please feel free to contact me, and I'd be happy to share more information. So at this point, I'd like to hand it back then to answer questions and so on.
Thank you so much, Polly and Maria and Claudia. I want to make sure that now we have an opportunity to turn it over to our attendees to take their questions. So just a reminder to everybody that if you have questions, please type them in the Q&A window that is located below the chat window. And Polly, we actually have a couple of questions have come in already, and I would like to also see if Maria and Claudia would like to weigh in on these. So the first question is kind of operational, and with respect to the community health leaders that you are deploying, do they offer door-to-door service, or do they organize some sort of health camps in order to provide treatment and disseminate information and other services?
So they work within their communities, and so if you have, for example, 15 families in the community, then they would attend to all of the community members within their particular community. So I guess in answer to the question, I guess door-to-door type service. Now, on the other hand, the Ministry of Health does send out doctors periodically to the communities for vaccination programs and things like that. And the health leaders do tie in with the Ministry of Health.
Got it. Understood. Thank you. And another question that's related to the service and the program, and again, this one might be very good for Maria or Claudia as well, is if the not, and some of the case spoke to this, if the nurses or doctors feel that the collected data from the patients indicates that there's really a need for emergency aid or something that is a more complicated procedure, how do they get back to the patient and put that into a play?
Maybe I'll ask Claudia to answer that question. Virginia, could you translate the question for Claudia?
Hello, Claudia. Hola, Claudia.
¿Sí? Hello.
So Virginia, the question was if there's an emergency situation, how the program handles that. So if you could ask Claudia to respond to that, please.
Yeah. Claudia, la pregunta es si hay una emergencia, ¿cómo ustedes se acercan al paciente? ¿Cómo ustedes tienen retroalimentación del paciente? ¿A través de los SMS? ¿Aló, Claudia?
A través del expediente clínico que tiene cada uno de los pacientes que llegan a nuestra unidad de salud.
Okay. Claudia said that they get back with the patient to all the system that MINSA has around the community. So they are keeping in contact with the health leader and to all the system from MINSA. MINSA has different offices down the communities. Hello?
Fantastic. That's very helpful. And did you want to add anything to that, Polly?
Yeah, I would. So with our particular system, typically what happens is that if the health leader thinks that there's an emergency situation, they will text Claudia, and then she will actually call them back and ask for more details of the symptoms and record those. And if she feels the need for an emergency intervention, sending out an ambulance, she will make arrangements because she's working at the hospital in the Ministry of Health, and then she'll arrange for an ambulance to be sent out to bring in the patient to the hospital.
Thank you so much, Polly. It looks like we have one of your team members, Ruth McDermott-Levy, who's also adding to that by chat, saying yes, that they can call in. So your entire team is chiming in here in whatever way they can. It's fantastic.
Great.
We have another question came in regarding some of the students that were engaged with this program, and this person would like to know if during the course of the development of the program, if it was the same group of students or did students come in and out as they graduated. So maybe a question to the retention rate and overturn.
Yeah, so we've had a number of students working on this, and actually even some of the students who graduated as alumni, they're continuing to work with us. But we are bringing in new students, particularly the students at UNI. We have a number of new students who are helping in further developing the software there. And so it's really a collaboration and continuing program with new students entering the program as well.
That's fantastic. I'm sure it's a tremendous experience. On the note of these type of projects and similar types of projects, we have a question from someone who's working on IEEE's Global Humanitarian Technology project competition and looking at rural health data connectivity in Pakistan. And he's having trouble tracing current systems in place. So based on your experience in developing this program, if you could speak to what was a good starting point or what really was effective for you in collecting data and understanding the infrastructure in place to appropriately develop your program.
So we were actually building on a health program that was established by the Catholic parish in Waslala, and we've been working with them for many years on clean water distribution projects as well as health outreach clinics. So we were building on some existing program that was somewhat in place at the time. Subsequent to that, the parish actually got out of running some of the social programs, and that's when we shifted to ADIS, which is the NGO that we're working with now.
So if you had to approximate how many years total, basically from the parish work all the way to the ADIS and then yourselves, and how many years total would you say has been kind of invested in developing programs in the area? Maybe
more than 10 years.
Tough to approximate. More than 10 years. So which speaks to the nature of relationship building and just the kind of investment that needs to be made when you try to build a sustainable program. It really does require some substantial time.
Absolutely.
So we have more questions pouring in, a lot of curious folks out here. So one of the things kind of coming back to operational elements is, do the community health leaders only do basic checkups, or are they trained for basic prenatal care, vaccinations, or community health awareness as well?
You know, I think that Ruth would be best to answer this question. But I think what we've been doing is working with them to be able to be competent in measuring basic vital signs, as well as you know, development of a mother as she's going through pregnancy, and but we've also held workshops on you know, breastfeeding and other related things after a child is born. So you know, it really spans the whole range. Now, there are also midwives in the communities as well that support the health leaders. So you know that infrastructure is there with the midwife as well as the health leader. Got
it. And we'll let Ruth, if she wants to add anything to that, she can add through chat and we'll layer on. Oh, she just did. She is so efficient. They do basic health assessments and provide a small amount of basic medications. Some do emergency deliveries of babies. So it seems to be on more of a case-by-case basis with particular CHLs. So another question has come in regarding the program as a whole. Can you speak to the sustainability of the program with regards to funding and the business model?
Yeah, so that's been our biggest challenge, and we're still really trying to work that out. We've come up with some concept ideas for regional pharmacies to support several communities, and trying to use potentially some income from that type of business to support the program. We're still trying to develop that model, and it's not in place yet, but we're certainly looking at sustainability. But it is a big challenge because you know, the health leaders who are working with us, they're all volunteers. The healthcare system in Nicaragua is a free system for the Nicaraguan people, so it's definitely a challenge.
Absolutely, and I guess to layer onto that, somebody wanted to know if you receive any government support. So I don't know if that has played into also some of the funding aspects or not yet, or something that you're looking forward with.
Right. Right now we have not received any government funding. That's one of the things that we're trying to work with the Ministry of Health because they do see that this is the way of, at a relatively low cost, improving the quality of healthcare that people are receiving in some of these regions where they don't typically get high quality healthcare. So there's certainly interest in the Ministry of Health, but we're still working with them. And all the funding that we've received so far has been from foundations and the NCIA, so we're still, we're actually looking at potential government funding, but we haven't secured any at this point.
Thank you. So I'm gonna kind of allow myself a little liberty here and ask a question while we have other folks contemplating theirs. I'm going to look towards the hardware and software side of the program, and you mentioned some of the equipment. You mentioned, you know, you made changes to the solar chargers, and also you talked a little bit about your rapid SMS platform. So I'm wondering, with respect to the choices that you made around your equipment, what motivated some of the decisions? I know that, for example, with the solar charger, you were looking at a charger that provided a greater power output of 4 watts. But are you still looking, first and foremost, what made you decide to choose those components? Are you still looking for constantly new equipment or something that's going to provide even better service? And in terms of the SMS platform, the same question. I know there's alternatives such as Frontline SMS as an example, and why or why not have you chosen the one that you are currently deploying? That's a lot of questions in one, I hope.
Yeah, so in terms of the hardware side, we've certainly been looking at different solar charger models, and I'm still not very satisfied with what we have. We are having problems with some of the cabling, and the connectors are relatively weak. So if there are suggestions for other types of solar chargers that are more rugged and still low cost, we'd certainly welcome that feedback. In terms of the software platform, what we found with the Frontline SMS was that it was very good for broadcast messaging, but not for necessarily receiving the SMS messages and storing it in database. So that's why we chose the rapid SMS, which really works better for that purpose. And yes, we are continuously looking for you know, upgrades. One of the things that I'd like to do in the next year or so is to look at a lower cost computer server hardware. I don't think that we have the optimum one at this point, but you know, given the priorities and where we're trying to go, that we have settled on some things that are working well, and rather than you know, trying to upgrade those, I think working on more expansion of the program and more on the transitioning out from one region to other regions and so on has been where we're putting our efforts, given the limited funding and time that we have.
That's really insightful, and we will definitely here at E4C be trying to help you out in that process. At this point, we are 1 minute out. I don't see other questions, and I want to make sure we have enough time for everybody to grab some vital information about this webinar. Just as a reminder, thank you for everybody for attending. We really appreciate it. Thank you to our presenters, to Polly, to Virginia, to Claudia, for especially calling in from Nicaragua. We couldn't be more grateful for your participation today. Muchas gracias. a ustedes. And also, we'd like to remind everybody that, and also Ruth, thank you for participating through our chat. It's very exciting to have you join us. Everybody, please join us on engineeringforchange-webinars.org, where you can find information about upcoming webinars. Also, for those of you who are seeking to get the professional development hours, the code is listed on the slide right here. Please email your name along with the day that you participated in this webinar, the name of this webinar, to the email address listed here, eab-ceuadmin@ieee.org. Should you have more questions that we didn't get to tackle in this webinar, feel free to email us at webinars@engineeringforchange.org, and we will be happy to pass them on to Polly and his team. And also, don't forget to become an E4C member. We send information all about our upcoming webinars to members. That's a member benefit. You never have to go to the site to check when something's coming up, because you'll get that a note in your inbox, along with our newsletter, as well as other opportunities like our blogosphere roundup. So thank you again, everybody, for participating. We look forward to seeing you on our next webinar, June 5th, with the Frugal Innovation Lab. And thank you again to our presenters, and have a great day no matter where you are. We hope to have you join us soon.